Healthcare careers shouldn't be a mystery, and they shouldn't be reserved for people who already have connections or know the right people. My name is Tanvi, and this is Healthcare Unveiled, where we have honest conversations with healthcare professionals about their real journeys, the good and the challenging parts, so that you can figure out if and how this path might work for you. Today we have Dr. Meghan here. Hello, and how are you?
Good. How are you doing?
I'm great, thank you. So just to start off, can you introduce yourself and tell us a little bit about what you do?
Sure. So I'm a comprehensive ophthalmologist at Penn State in Hershey, Pennsylvania. What that means is I see mostly adult patients and also some children. And I do comprehensive examinations as well as surgical procedures and minor procedures. The surgical procedures are mainly cataracts, but can also include pterygia excisions or minimally invasive glaucoma surgeries. And the procedures I do range from glaucoma lasers to um, lasers for diabetes or after cataract surgery and injections. So I have a mix of outpatient clinic and surgery. I also am, because I'm at an academic center, I'm involved with teaching residents surgical and clinical skills as well.
Okay, awesome. So what initially drew you to eye care, and what was your training path like to get there?
So, in undergraduate, I focused a lot on the arts, but I was still taking pre medicine classes as well.
Hmm.
Uh, and once I got to medical school, there's kind of two pathways that you have to decide between. And one is if you're going to be primarily clinical, and two is if you're interested in surgery.
Hmm.
And once you choose one of those paths, you've already made a pretty big decision because you're ruling out a lot of subspecialties or fields.
Hmm.
So once I took my general surgery rotation, I knew that I liked working with my hands and I liked the surgical component of medicine. Um, but then, intellectually, I was always drawn to things that were visual or neurological. I really liked psychiatry, I really liked neurology, and that kind of led me to ophthalmology. Ophthalmology is both surgical, but it's also very clinical. Um, and there weren't that many fields that blended those two things in the same way.
Hmm.
And because of my background in the arts, I think I just felt more connected to a field that specialized in vision. And it felt very fulfilling to me to help people maintain good vision. And I just felt more connected to that purpose, I think, when I compared it to the other fields I rotated through in school.
Hmm. So what made you focus more on an art uh, pathway through undergrad rather than go like a more typical route of doing something like biology?
I think I just liked the arts. So I tried to let my gut guide me in decisions like that early on.
Mhm.
Um, I didn't really know what career I would end up in. And my mother was a neonatologist, so I spent a lot of time at the hospital when we didn't have babysitters.
Mhm.
So medicine felt like less of an unknown to me. So I took those classes for practical reasons. But the arts, I think, were the classes that really challenged me creatively, and I just gravitated towards those classes. So I naturally ended up with enough credits for a major in art history, and I liked the concepts in art history where You look at a painting or you look at a work of art and you contextualize it, and you can learn a lot about a time and a place and a period or someone's mindset just by looking at what they created. And I think that's not very removed from how we approach clinical medicine, especially in ophthalmology. You're really using a lot of visual cues and putting them together to come up with a diagnosis. And even outside of ophthalmology, that's the basic principle of medicine is you listen, you use your stethoscope, you use your blood pressure, you use vital signs, you use the patient's story, and all of these things lead you to a diagnosis or, um, you know, a set of problems that a patient needs help being guided towards treatment for. So, in some ways, it was the same interests that have kept me challenged in medicine as well.
That's awesome. I never realized there were so many parallels between art and medicine. But do you think that pursuing a major like art history helped you stand out in med school applications in terms of like competition? Hello?
Hello?
Oh, hi. Yeah,
Okay.
I can hear you.
Hi.
Sorry.
Sorry. I don't have the best connection out here.
No worries, no worries. I was just asking, do you think that pursuing a major like art history helped you stand out in terms of med school applications and the competition you had?
Um, I'm not sure. It was definitely than what most of my peers were studying in undergrad.
Mhm.
But I do think in some ways it made it more challenging um, to show that I had a strong background in the sciences,
Mhm.
which I think is the primary thing that medical schools are looking for is your ability to continue to perform in science classes in particular.
Yeah.
And I think increasingly we're less reliant on standardized tests to show that ability. And I think taking more science classes maybe would have helped me on the path uh, earlier on. So when I applied, I first applied to medical school and I did great on my MCAT, but didn't really have many sciences on my resume, and I got waitlisted at several schools. But it took me another year to basically show that I was capable at taking science classes um, to then get into medical school.
Mm.
Um, so if I had to give advice to my former self, I think I would have done everything the same in undergrad. Um, Maybe taken an extra year to take more science classes or try to squeeze in more science classes my senior year of college, just so that I could show medical schools that I was able to do this and maybe I would have been higher on their list. I'd be less of a risk as a student because they want to accept people they think will excel. Um, and I think the more science classes you have, the more you can ensure to a school that you're going to do well and you'll succeed if they accept you.
Yeah. Mhm. Um, so what does a typical day look like for you, and what's the range of conditions that you would see generally?
Um, So I have my operating room days and then I have my clinical days. And my operating room days, I'm usually at the surgical center, ready to start by 7:30, and I'll do about maybe 8 to 10 cases in a day. Again, we're at an academic center, so in private practices, surgeons are doing almost double this, but we just don't have that capability at an academic center. Our cases tend to be more complex. They tend to be the patients that are not able to be cared for at a typical outpatient center in the community.
Mhm.
Um, and then on my clinic days, I'm seeing patients with cataracts who need surgery. I'm seeing patients with glaucoma who need medical management or surgery, diabetes, um, people who don't know why their vision is decreased, and you kind of have to help them figure out why and what they need to do um, to better control their blood sugar, or if they have macular degeneration, start vitamins. It's really a huge range of pathology that I see because I'm out in rural Pennsylvania where there is an access to care problem when it comes to eye care.
Mhm.
Um, and then I'll have other days where I'm doing both. I'll spend the morning at the surgical center and the afternoon in clinic. Um, and sprinkled in, there'll be resident cases where the residents will be doing the surgery under my supervision. Those are the cases I have most fun on. I enjoy teaching and watching the residents improve over time. It's a really rewarding experience.
Mhm.
Um, but every week feels different, and every day of the week is different. So it's definitely not boring.
Yeah, awesome. And you were talking about access to care. So, what barriers to eye care do you see for certain populations, and what happens when patients delay care because of inaccess to care?
Um, I guess the main barrier is that not all insurances cover eye health or eye care.
Mhm.
So a lot of patients kind of forego that part of their health care. And in addition, in medical school, there's not a lot of ophthalmology exposure. And so oftentimes things get missed in a primary care setting when it comes to eye care until they progress to the point where the patient is no longer able to make it to visits or function um, or do their activities of daily living.
Mhm.
um, and so that's a huge barrier, is kind of patients being able to get their foot in the door for an eye health assessment. And then the second barrier is that um, we're the only academic center for, um, probably a travel distance of 2.5 to 3 hours. And what that means is that everything else in the area is a private practice that doesn't take Medicare or that doesn't take Medicaid. Um, and so any patients that don't have private insurance um, have to come to our center, and the wait can be several months. Um, and cataracts can progress in that time. Diabetic macular edema can progress in that time. Diabetic retinopathy can progress. And sometimes patients um, progress to the point of blindness by the time they're able to see us. And you can imagine that makes it hard for them to even get to their appointment when they're living in very remote areas.
Yeah.
Um, so there's several barriers in rural areas in particular for those reasons.
Mhm. What would you say is the most frustrating aspect of your work, and how do you handle having to deliver like difficult news to patients about vision?
Um, Frustrating. Um, Working in medicine can be challenging because a lot of your job is not always what you signed up for. So a lot of the bureaucracy of working in a hospital can slow things down and limit the volume of patients you can see in a day or the surgeries that you can do. I guess what's often frustrating to me is that I'm forced to have patients waiting 2 or 3 months for surgery,
Mhm,
um, just because of scheduling and availability of operating room space. And that can be really hard. Um,
mhm,
but in terms of delivering news to patients, I think when you're a surgeon, there's a different kind of gravity to the concept of do no harm,
mhm.
because when there's a complication during surgery, you know, there's a physical connection between you as the surgeon and what happened to that patient.
Yeah.
And it can be very emotionally charged. Um, and that's kind of what I'm learning as a new surgeon now in my first year. But I found that honesty is the only way to approach these things. And just being fully frank and honest with the patient and letting them know what to expect if there was a complication during surgery. And a mentor of mine would always include in his consenting process for surgery, um, you know, there's always risk to surgery, but no matter what happens, we will take care of you. And I think that sentiment really resonates with patients.
Mhm,
Um, and oftentimes I find that um, I'm harder on myself and have higher expectations than the patients do. Um, and they're more accepting of complications, and I've had to learn to, you know, pick myself up and keep moving because other patients need you to care for them. And that can be a really challenging skill to learn, especially when you're starting out.
mhm. And what's the biggest misconception that you think people have about eye care or eye health?
Um, I think that cataract surgery is routine.
Mhm. Yeah.
I think a lot of people don't realize that intraocular surgery uh, can can result in complications that are blinding.
Yeah.
Um, and so oftentimes they want surgery when you don't feel that they need surgery yet and the benefits don't outweigh the risks at that time. Um, and I think that's a huge misconception that everyone gets cataract surgery and so it must be routine and easy. And even though it's low risk compared to other surgical procedures, the risk is not zero, and they're very real if they happen to you as a patient.
Mhm.
So I think that's a big misconception.
Yeah. Mhm. And to change gears a little bit, where do you see eye care heading in the next 10 to 20 years, and what advances are you most excited about right now?
Ooh, um, I think AI is going to play a huge role in eye care.
Mm.
We're already starting to use it for diabetic screenings, um, but especially in places like Pennsylvania, where not every clinical center has an ophthalmologist. Not every hospital has an ophthalmologist.
Yeah.
Being able to send photos or images of a dilated exam um, and being able to send them to an ophthalmologist at a remote site can really help providers triage how to care for patients in the moment.
Mm.
And I think telehealth is going to be a very big part of ophthalmology in the future and improve access in rural areas.
Hmm. Can you share a memorable patient story that reminds you of why you do this work?
Sure, there's so many, even after only 3 months or 4 months of being an attending. Um, but I think one patient um, really stood out to me. It was a patient with Down syndrome, and she had bilateral cataracts. And she had kind of been bounced around in the community for over a year.
Mm-hmm.
And she first went to an outpatient private practice, and they referred her to a retina specialist, who referred her back to the initial doctor, who eventually said, I can't do your surgery at my surgical center, um, because we don't do general anesthesia here.
Hmm.
Most of the time, cataracts are not done under general anesthesia. But when you have a disabled patient that can't reliably stay still for surgery, you need that to do safe surgery.
Yeah.
So by the time they had been referred back and forth, it had been 4 months, and her cataracts had progressed to the point where she could no longer walk down a hallway without assistance.
Hmm.
And so her sister had to basically help her to the bathroom, help her to do essentially everything during the day. And that was a huge burden on the family and really took away from her quality of life. She used to read, she used to color, she used to do a lot of up close work before the cataracts. And so we were able to do her surgery at the hospital. Um, and when her sister brought her to the 1 month follow up, she was in tears because um, her baby sister could finally see the cars on the road on
Hmm.
the way to the hospital, and was pointing out all the different colors and was just looking around like she, um, had never seen any of it before. And I think that was a really rewarding moment for me because it's a very life altering thing to lose your vision. And this was a very preventable condition, but because of the way our healthcare system is set up, she suffered for the better part of a year before we could help her with the cataracts. So that was a really meaningful moment for me. That was one of my first cases as an attending,
Hmm.
um, and it really gave me fuel to keep going.
Yeah. Awesome. So to kind of end off, what would you tell someone considering eye care as a career, and what qualities do you think make someone well suited for this field?
I think ophthalmology is such a great field. I think you can really make an impact in people's lives in a very tangible way. Um, and, you know, for most people, vision is the first way we interact with the world. Um, and when we help patients preserve that, we're helping them preserve their way of life and their independence. And I think that's so special and really rewarding.
Mhm.
And I think it's also such a growing and fascinating field. There's new technologies to learn all the time. There's like minimally invasive glaucoma surgery, for example, is a growing field where there's new technologies, it feels like almost every year. So you can constantly learn new skills and challenge yourself um, to learn new surgeries. Um, and it's just a very, uh, a very exciting field in terms of new technologies in that way.
Mhm.
I think it's also very globally oriented. So um, people are obviously practicing ophthalmology all over the world. But I think, unlike other fields, there is a very connected global community when it comes to ophthalmology. And there's always this kind of transfer of ideas from India and Moorfield in Europe and, our institutions here in the US. And people are doing different surgeries everywhere you go. There's multiple ways to do the same thing. And there's a lot of exchange of ideas within the field. And I think that's what makes ophthalmology unique in many ways.
Mm-hmm.
And also, like our exam is completely different than anything else in medicine. You have to use a slit lamp. You have to learn how to use an indirect. And these are challenges that are very unique to our subspecialty, and they open a whole new world to you once you learn how to use them. There's so much that you can see and diagnose just by being able to adequately examine an eye. Um, I've diagnosed everything from, um, multiple sclerosis to um, syphilis to, um, you know, diabetes, high blood pressure. I've diagnosed all these things just by looking at someone's eye.
Mm-hmm.
Um, and that's, I think, such um, a cool concept to be able to just use your visual examination skills to bring so much light to a patient's diagnosis and treatment plan.
That's
Um,
awesome. Thank you so much for being on the podcast today. I'm sure anyone that's looking to go into ophthalmology or eye care would learn so much from hearing you talk.
Thanks, Tanvi.